Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. All right, so today we're going to talk about a basic approach to the gastric emptying study. This is a pretty straightforward and generally not terribly complicated scintigraphic study. But it's been considered the gold standard to assess gastric motility and look for gastroparesis. And so this sort of study is done, mostly in those sort of circumstances. In some less common scenarios, we're going to look for overly rapid gastric emptying, which is another possibility. It's going to be pretty important to just make sure, the key kind of things here are, making sure that the study is an adequate study, the region of interest is positioned appropriately, it's appropriate to the patient anatomy, and then ultimately understanding the context of what's going on with the patient, and then with the quantitative measurements provided, assess the degree of whether there's rapid or delayed emptying. Okay, so again, big picture, how do we do this? So first it's essential to understand the indication, the patient history, and what does that really mean in this particular circumstance? So first of all, you want to understand what is the concern initially. Is it for rapid or is it for delayed emptying? Is the patient on medications or have conditions that would affect transit through the GI tract? Do they have metabolic derangements? Has there been, some evidence of bowel inflammation? Have they had prior surgery? Is there an infectious process going on? Are they on prokinetic medications? Are they on opiates? Basically, having a sense of that can be pretty important. And then, especially since you'll have to make sure that the region of interest is in the right place, you're having a sense, especially if the anatomy is altered, to look at prior anatomic imaging, frequently CT or MRI, to see, if there's going to be some abnormality we have to account for to make sure that we're placing and measuring counts in the right place. All right, so that's going to be kind of the key background to think about for this sort of study. And once you do that, the basic process is to go through, QA the study, understand how much the patient ate, things like that, and then frequently you'll have the counts, and then whether you plug that into a calculator or it's automatically done for you, it'll give you the degree of emptying. At various time points, you may have 1 hour, 2, 3 hours, 4 hours. In some circumstances, some institutions might also have, a half hour. So we're going to assess the stomach activity. And then, last thing, as usual, it's always good practice to make sure, is there abnormal tracer elsewhere in the study? So let's take a look. So this is an appearance of a gastric emptying study. Here we've got the region of interest placed over the place where we expect the stomach to be. That's the normal appearance of where that is. We have both anterior and posterior projections. Now, again, it's going to be important to correlate that with prior anatomic imaging, but this does have a good appearance. If this is the only study that we have, you want to know, did the patient, have, the normal, the usual type of meal that we provide, or did they have, it can be like there's can be like an egg sandwich. We sometimes get an oatmeal, or was it a liquid ingestion? That's kind of going to have different parameters. You want to know, did they consume, most of that meal? If they only ate a little bit, it's going to affect accuracy. And those are kind of the things that are going to go into this as well. And so once you just made sure that this is, you have that context, the ROI is placed appropriately, and, you can track that, see if the patient has moved, see if the ROI is appropriately configured with any motion. You're going to be provided counts, at different time points. And then, these counts from the anterior and posterior projections are ultimately then going to be, then you can when you place these into a prefigured calculator, or will be automatically provided to you, the degree of emptying for different time points, frequently an hour, 2 hours, 3 hours, 4 hours. And then, there can be some calculations and graphing going on. But typically what we use, most recent criteria at the time that we make this video is that, if there's concern for rapid emptying, right? Typically, if there's, there's less than 70% remaining activity in half an hour, which is not a time point we've done here, but, additionally, if there's less than 30% remaining after 1 hour, right? So like the vast majority of stuff, more than 70% having empty after an hour, that's rapid emptying. And then delayed emptying has a number of different criteria. Typically, the 4-hour time point is the most useful, sensitive, talked about in the literature, but more than, 90% remaining after 1 hour, more than 60% remaining in the stomach in 2 hours, more than 30% in 3 hours, or 10% in 4 hours are typically the thresholds that are used. And so we're going to see here that there's kind of like an emptying, that's sufficient at 4 hours. And I think we can zoom up here and see that there's, only maybe like, it's 98% emptying, so only 2% remaining at 4 hours. This is an, adequate emptying, and there doesn't seem to be, concern for a rapid emptying either. So, the other kind of important thing, it's not very, very common, but we want to take a look at is there any sort of concern for reflux? Is there activity that we're seeing back into the esophagus? Is there aspiration? Or are we seeing lung activity? Those are kind of the additional things to think about. And so, with this sort of study, those are the major things to think, to consider. So big picture again, just how do we approach the gastric emptying study? We want to first understand what is the concern, what is the clinical context, the anatomic background of the patient, what are the things that impact GI transit, what is, and then what are the things that affect the quality of the study, how much of that tracer was actually ingested, is our RI good, does the patient move, and then we want to track that activity over time, comparing it to the usual thresholds, and then we're going to just do a last check and make sure there's not abnormal tracer elsewhere. It's, it's generally a pretty straightforward exam.